Good evening, students. Welcome to Uma Misra's Med classes. Today's topic is lung abscess. Lung abscess. It's a question. One of the competency is describe the etiology, gross, microscopic appearance, and complications of lung abscess. Because we must teach the students according to the competencies laid down by the NMC in the syllabus. Beyond that, we should not go, and if we go also, that is for the that is not very much required for their examination purpose. For knowledge sake, it could be, because you see here this question competency includes etiology, gross, microscopic appearance, and complications of lung abscess, but not included the treatment aspect. So, treatment aspect I am purposefully leaving pertaining to competency itself. So, define lung abscess is defined by a necrosis. Students, if you want to write also, you can write. I am going slow also because I am having a note and I have made it from different books, and according to you can write also. So necrosis and cavitation of lungs following microbial infection marked by a cavity more than 2 centimeter in diameter. So if less than 1 centimeter, definition is the necrosis must be there, cavitation must be there, and cavity size must be more than 2 centimeter in diameter. Otherwise, it is not a lung abscess. 1 centimeter below, it is not a cavity. Neither a cavity nor it can be told as a lung abscess. So, definition wise, etiologies, there are 2 types of lung abscess. Primary lung abscess, generally 80% of lung abscess is primary variety. Secondary variety are 20%. What is primary then? Primary is generally this is the lung abscess. I have already told in my previous video that lung abscess is due to macro aspiration. So this is exactly due to that, due to aspiration of anaerobic bacteria in absence of underlying lung condition or systemic condition. Aspiration of bacteria from where? Oropharyngeal, 90% cases oropharyngeal, or by the pharyngeal, or by the gastric content event. So oropharyngeal because of the bad oral hygiene, dentitions, poor dentition, different causes are there. So this primary lung abscess due to oral bacteria, anaerobic bacteria in absence, underlying lung condition will be not be there, or systemic condition will be not there. This is a primary lung abscess. Secondary one, due to underlying lung condition. Secondary lung abscess is 20%. That has to be over a lung condition. The pre-existing lung condition must be there. Foreign body might be a cause. If at all foreign body, so there is lung abscess secondary to that. Tumor, cancerous condition, systemic diseases like HIV or AIDS, immunocompromised condition. So these are the causes of systemic condition. They are responsible for the secondary lung abscess. Then what is acute abscess? Chronic lung abscess, acute lung abscess. Acute lung abscess is around 60% of the cases are acute lung abscess. Less than 6 weeks of duration. You remember this one. Acute lung abscess is 6 weeks and 60%. Chronic lung abscess more than 6 weeks, more than 1.5 months, and it is 40% in occurrence. So by this time we knew what is the definition, what is the etiology, what is the chronic abscess, what is the acute abscess, what is a primary lung abscess, what is a secondary lung abscess. Epidemiology. What is epidemiology? Very in short, epidemiology, because epidemiology is included in etiology. Because this is the competency. You have to write in answer also. Middle-aged man, common. Middle-aged man, common. Major risk factors are aspiration. Aspiration, what are the risk factors for aspiration? Altered mental status, somebody is comatose, mental status, and aspiration occurs because of the loss of pharyngeal reflex, laryngeal reflex. Alcoholism, those who are alcoholic debug after a full stomach of alcohol. Dead drunk patients, drug overdose, seizures, those conditions are responsible for coma. Bulbar dysfunction, there is paralysis of the bulbar muscles in different conditions. Neuromuscular disease, motor neuron disease, very advanced stage, and esophageal dysfunctions or dysmotility syndromes. Esophageal dysmotility, so that the gastric contents come up and it is aspirated inside the lungs. There are 2 major pathogens for lung abscess. One is anaerobes, mostly anaerobes, and microaerophilic streptococcus. Microaerophilic streptococcus and Students, you remember, there are two. Polymicrobial lung abscess is common also. Common, not common, but it is existing. But most important pathogens for lung abscess is microaerophilic streptococcus and mostly anaerobes. First is anaerobes, then microaerophilic streptococcus. So this is the epidemiology of lung abscess. Pathogenesis, coming to pathology and pathogenesis. This includes the competence of gross and microscopic appearance. Here, the pathogenesis occurs. Primary lung abscess is by anaerobic bacteria and microaerophilic streptococcus. I know. Primary lung abscess is by these two. Pathogenesis. What are the other pathological organisms? One is Peptostreptococcus, Prevotella species, Prevotella, Prevotella, Prevotella species. Peptostreptococcus, bacteroids, these are all anaerobes. Streptococcus milleri, microaerophilic streptococcus. These are in the crevices, gingival crevices. They reside in the gingival crevices inside the mouth cavity. When aspirated oropharyngeal content are aspirated inside, they go and lodge in the lung parenchyma and they cause abscess, necrosis, and as such. I'll come to later. So, this occurs when they enter inside the lungs parenchyma. They sit in the lodge in the lungs parenchyma. This takes 7 to 14 days to do their pathology. They cause tissue necrosis. The anaerobes and all these organisms, they cause tissue necrosis. One, tissue necrosis. First is lodgement. Second is tissue necrosis. Third is cavitation. It is told that microabscesses are formed and then coalesce together, forming a lung abscess. Always remember, anaerobic bacteria is mostly responsible. Polymicrobial also. More tissue destruction than polymicrobial infection. Polymicrobial infection is also responsible for lung abscess. But you see, destruction is always more in anaerobes than polymicrobial. If many bacteria are responsible, so lung abscess is a bit less. The cavity size is less, necrosis is less, virulence of organisms are also less. Anaerobic lung abscesses are bigger in size, they cause more destruction of the lungs and etc. etc. More complications also. Then secondary lung abscess. Secondary lung abscess, you students, you know that it occurs in the systemic diseases associated with some other lung pathology, foreign body tumors, cancers, etc. due to bronchial obstruction. Mostly due to bronchial obstruction, malignancy or foreign body, underlying immunosuppression. Suppose immunosuppression is there. Immunosuppression. Why they occurs? Because these conditions, these systemic infection, obstruction, cancers, tumors, foreign body, they cause the clearance of organism mechanism. Those mechanisms responsible for clearance of organism from the respiratory tract, they are jeopardized. Jeopardization of the clearance mechanism of the oropharyngeal secretion from the lungs parenchyma or the lung passage. So this causes abscess formation. They are lodged and different mechanism occurs, necrosis occurs, tissue destruction occurs, then abscess formed. So conditions of immunosuppression, solid organ transplantation. Those conditions, solid organ transplantation, definitely the different organ transplantation, they are immunosuppressive agents, they are on steroids, they are different immunosuppressive agents. That's why the clearance mechanism is jeopardized. So the lodgement of organism is easier and the tissue destruction is also. Bone marrow transplantation, impaired host defense mechanism, impaired host defense due to and then septic emboli. Sometimes septic emboli may cause secondary lung abscess. Tricuspid valve endocarditis, tricuspid valve endocarditis, they are responsible for the lung abscess also. Pathology, gross pathology, because this is a competency for gross pathology. So, gross pathology is lung abscess occurs in two segments. They are all dependent segments. It is more common in the right lungs, superior segment of the upper lobe, they are generally dependent one, and another is posterior segment of the lower. Right side is more effective because aspirated material is first enters these two segments. They are lost there and create the pathology. So, the gross pathology is that the lung abscess are present in the superior segment of the upper lobe and posterior segment of the lower. Sometimes no pathogens are detected from the lung abscess. No pathology. Generally, the mechanisms in which we get the pathological culture positive, like bronchoalveolar lavage, sputum examination, sputum culture, transtracheal aspiration, BAL, bronchoalveolar lavage. But sometimes, in spite of all the culture methods or the sophisticated investigation, the bacterial pathogens are not available to us. those are called non-specific abscesses. Those are called non-specific abscesses. Remember this, when no bacterial pathogens are available, then non-specific abscesses. When the putrid abscess, foul smelling, halitosis is present by the mouth, in the mouth, halitosis, foul smelling, breath, take it granted that the abscess is definitely due to anaerobic organisms. Secondary lung abscess, like location of secondary lung abscesses varies, but these are our primary lung abscess. Secondary lung abscess, the site varies. Anyway, Pseudomonas aeruginosa, other gram-negative rods, they produce secondary lung abscess. Sometimes significant incidence of fungus lung abscess also present. Immunocompromised host, solid organ transplantation, these are all secondary lung abscess. These are gross pathology. They can be anywhere. Clinical features are definitely irritating cough, severe cough, copious amount of sputum production, drenching sweats, so much sweating will be present, shaking chills, sometimes shaking chills is present, fever with shaking chills, chest pain is there, night sweats, profuse amount of night sweats are present, fatigability is there, anemic patient becomes anemic within 4 to 6 weeks. Foul tasting, the test is sometimes foul tasting, foul smelling, sputum also. If Staphylococcus aureus is present, then fulminant course. Fulminant course, patient becomes more serious, more fatigability, more shock, even shock, patient goes to shock, high fever, rapid progression, and patient becomes more ill. On examination, if you examine the patient lung abscess, fever must be present, poor dentition. The dentition, if you examine thoroughly the mouth cavity, poor dentition, abnormal, poor oral hygiene might be present, gingival abscesses, gingival diseases must be present. Then amphoric or cavernous breast sound. Cavity means cavity is there. If I go to a clinical examination, then a amphoric cavity, sometimes big cavity with a patent bronchus, amphoric breast sound will be present. So normally there is a cavernous breast sound present. Digital clubbing is there. On a general examination, digital clubbing is there, and absence of gag reflex might be present. If you thoroughly examine, neurological examination also present. Lung abscess patient might have a gag reflex, so negative, or the gag reflex is absent. Absence of gag reflex. Diagnosis, how you diagnose the patient? X-ray. Diagnosis by clinical examination is very erratic sometimes. Lung abscess will be present, but your diagnosis might be missing. If at all the signs will be not present whenever the abscess is deep-seated. Small abscess, deep-seated, more than 5 centimeters from the chest wall. So no signs will be present to you. It's a clinically insignificant abscess, or you miss the diagnosis. So X-ray diagnosis is also very important. Thick walled cavity, air and fluid interface. Thick walled cavity means inflammation is around, thick walled, and the fluid and air interface is there. So fluid down or air is up. So cavity around, fluid down, and there is interface, air and fluid interface. CT scan shows better definition. CT scan or HRCT or CT scan even, thorax of the CT of the thorax shows better definition and earlier detection of cavity formation or cavitation, lung abscess, early. Whenever the necrotizing pneumonia also present, aspiration, necrotizing pneumonia, tissue destruction, and cavity is formed, early, imminent cavity, that his CT scan helps for the early detection so that we can give proper treatment and patient becomes okay within easier time or shorter time. CT shows also differentiation between malignancy and pleural effusion, also associated pleural effusion or empyema, or there is a tumor inside, or there is a foreign body inside. This CT is helpful and it is more promising evidence, confirmatory evidence by the CT scan than the X-ray. So the complications of lung abscess. If larger cavity, first complication is larger cavity, persistent cystic changes are there and hematocells present. If larger cavity is there, so persistent cystic changes around the cavity occurs. It doesn't heal. Then pneumatocells occurs. Pneumatocells, and that burst that may cause a pneumothorax or a empyema or a sudden collapse of the patient. Or if it is a big cavity, then the tension pneumothorax, etc. Empyema generally. Then bronchiectasis. If it heals also, then bronchiectasis occurs in a larger areas. Empyema, this causes empyema. Life-threatening hemoptysis. If through the abscesses, if some blood vessels on the wall or through the abscess goes and that burst during coughing mechanism or due to changes of pressure, that also gives a very heavy amount of hemoptysis, a massive hemoptysis. Sometimes person dies, and massive aspiration of abscess content. Lung abscess, one natural course was asked previously when we were students. What is the natural course of abscess, lung abscess? So natural course is one, so many days fever, pneumonia-like fever, necrotizing pneumonia, all on a sudden. The abscess cavity, abscess is drained to the bronchi, bronchus, trachea, etc., and copious amount of sputum is expectorated out. That is the natural history of lung abscess, which may not be present nowadays because of the antibiotic era. So many antibiotic and the organisms are not very much shows the virulence. So this natural course has altered. But if you ask questions very meticulously, you can get this type of answer from the patient, from the reply from the patient. Treatment aspect, I am telling for your knowledge sake, it is not included in the competency. So this lung abscess is completed by this. So treatment is 1950s, 40s. Penicillin was the drug of choice in lung abscess. For many days it was given because penicillin is also anaerobic. Anaerobes are responsive to penicillin. So penicillin has also a good effect on the penicillin, and the metronidazole also was given at the time, and the clindamycin was given. Clindamycin was superior to penicillin. Clindamycin 600 mg 8 hourly IV, then 300 mg IV 6 hourly. Clindamycin is a good drug for lung abscess. For many days it is good to be given. 6 weeks the treatment is generally 4 to 6 weeks treatment is given. Beta-lactam and beta-lactamase combination. Beta-lactamase and beta-lactam both combination. Once they are given ampicillin and sulbactam. One stable, then amoxicillin plus clavulanic acid. So ampicillin, sulbactam, then amoxicillin plus clavulanic acid is given 8 hourly. Therapy to be continued till radiological clearance of the abscess. When up to what? You give serial radiological X-ray, and if the abscess cavity radiological clearance of lung abscess or a scar formation occurs or impending scar formation, then you stop the treatment. This becomes 3 to 4 weeks minimum duration, and as long as 14 weeks also, 3.5 months also treatment can continue in lung abscess. Moxifloxacin could be a drug of choice also, 400 mg daily, effective as ampicillin and sulbactam. So beta-lactam plus beta-lactamase antibiotic. Note this, my dear students, metronidazole not effective because it is a agent anaerobic organism. It's agent anaerobic organisms, but not a microaerobic streptococci. It's against anaerobic. It gives metronidazole nowadays not used. Previously it was used because in polybacterial lung abscess, microaerobic streptococci is not responsive. But anaerobes are sensitive to this metronidazole. So nowadays the role of metronidazole is limited. When there is a foul smelling breath or halitosis is present, then you can add metronidazole also. Secondary lung abscess, the treatment is also like that, and according to the treatment, according to the underlying pathology, you treat the abscess, and complication associated if bacterial contamination or pneumothorax, hemothorax are present, then you can treat in that direction. So these are for your knowledge sake. Prognosis mortality is more than 20%, secondary 75% mortality, primary is 20% mortality. Primary is less because you know there is no other underlying conditions, but secondary has other underlying conditions. So mortality is high. So these students, complication, once again I am telling, complication is large cavity, cystic changes, pneumatocells, bronchiectasis change, second. Third one is empyema. Fourth one is life-threatening hemoptysis. Then massive aspiration of the abscess of the content and person dies. Thank you. So this finishes the lung abscess competency. Next class I will be dealing with COPD. Pneumonia we have completed pneumonia, and because this class will be not interactive classes, I am trying for interactive classes also. Thank you very much.